64 people. Excellent. Okay, let's start. So hello, you've been listening to me for Natteron for a while here. So I'm going to discuss the diabetes guidelines. And there is absolutely no way that I can provide a comprehensive overview of 300-page documents in 30 minutes. So I'm going to try my best, but this will be available on the website and will also be recorded on the website. So diabetes is a huge problem, and through CIHI, the last stats I could get were from 2013, 2014, that suggested we were diagnosing around 200,000 Canadians with new diabetes every year. So we have really done nothing to negate that, so I suspect our numbers are getting worse. The key message I want to drive home today is that individualizing therapy for patients with diabetes sits at the center of clinical decision making. So we're going to look at Jane. Jane is a 56-year-old female with past medical history of 2 children, 2 childbirths. She had a hysterectomy in 2010, a cholecystectomy in 1997. She has type 2 diabetes for 20 years, and she is 96 kilograms. Her meds are Judgement, gliclazide, Altase, and Crestor. And I'm sure that my colleague Krista, who just presented, would be so sad that I chose to use trade names as opposed to generic names. Her most recent hemoglobin A1C is 9.2. So you can see I have a picture of a clock, and maybe time is running out for Jane. That's a significantly increased hemoglobin A1C. So we will look at this at the end of the presentation, and we're going to answer a couple of these questions. So how should we manage Jane's A1C? Does Jane need aspirin? And what interventions could enhance cardiovascular or provide cardiovascular benefit to Jane?
Oh.
So,
Oh.
let me just. Oops. So, screening and diagnosing. The current recommendations, 2018 through Diabetes Canada, suggest that every 3 years for individuals who are age 40 or above, or individuals who are at high risk. And then when we look at our fasting plasma glucose or hemoglobin A1C, we can see that the glucose of less than 5.6, you have no diabetes. From 5.6 to 6, you are at risk. Fasting plasma glucose of 6.1 to 6.9, we deem you as pre-diabetic, and that encourages us to screen you more often. So that frequency can be anywhere between 6 and 12 months. And then when you have diabetes, it will depend on what your hemoglobin A1C is. You will be diagnosed with diabetes if you have a fasting plasma glucose of greater than 7. So I really like how the diabetes guidelines are laid out. The A, B, C, D, E, S times 3. So basically, we're going to look at each of these parameters here. And this is how we manage diabetic care in Canada. So the biggest thing that we need to do is try and avoid the major complications that happen with diabetes, the macro and the microvascular complications. And this was sent to you in a PDF form. is I think it's important that people spend a little bit of time to look at it. We're looking at macrovascular and microvascular. We're very good at looking at eyes and kidneys, but oftentimes we forget about the brain and the heart. And we know that quality of life is heavily impacted by those two organs. So the A in the ABCs of diabetic care is optimal glycemic control. And so an A1C, we're looking at, in most patients, an A1C for either type 1 or type 2 diabetes. And this presentation is really focusing on type 2. We're looking to have an A1C of less than 7. Now, when do we let it slide up and get less concerned? Is when somebody has had diabetes for a long time, because we know it's a progressive disease. We may let it slide up a little bit when there is recurrent hypoglycemia in the frail elderly or the patient with dementia, because we fear that they will fall. And then also when there's limited life expectancy. I used to say to my grandfather when he was in long-term care, "Here, Gramp, eat the black licorice, enjoy it, smile, don't worry about what your sugar is." Life expectancy is the quality over quantity. So when we look at how we manage diabetes, it's a little bit complex. But it's all based on what your hemoglobin A1C is. And so if your hemoglobin A1C is less than 1.5 away from target, then we may say to the patient, we're going to either start you on metformin, or if you are on metformin already, we will increase that. But something that often gets forgotten about in a doctor's office that really sits with registered nurses is healthy interventions, healthy lifestyle modification. That has to be at the forefront. And I think nurses are in a pivotal position to educate patients on that. In a very busy clinic, it is my hope that the RN is valued for her patient teaching. So when patients have a hemoglobin A1C that is greater than 1.5 above target, metformin should be started immediately. And if they're already on metformin, a second agent should be added. And then for the group of people who are having maybe diabetic ketoacidosis or having severe hyperglycemia, you will be adding insulin to their metformin. But other questions that clinicians will ask when they are looking at what type of treatments required is, does this patient have clinical cardiovascular disease? Yes. Then we look at the agents. And so these are second-line agents. First-line agent would be a metformin, but second-line agents that have some demonstrated cardiovascular benefit. And these are shown through clinical trials to have some cardiovascular benefit. And I'm going to show you a little table that shows the different medications. So there are 3 listed here. 2 of them are level 1A, grade A recommendations, and the other is a grade C, level 2. So, much less robust confirmation for use of that. But there is definitely diabetic medications that have a cardiovascular benefit to them. If the patient does not have cardiovascular disease, and I find that kind of interesting because whenever you speak to an endocrinologist or whenever you speak to a cardiologist, they will say that having type 2 or type 1 diabetes is the equivalent of cardiovascular disease. And so many of our risk calculators have diabetes right at the forefront, and that is the biggest number when we are looking at risk. So if the person does not have diagnosed cardiovascular disease, the biggest parameter that they will look at when adding additional agents is, many will look at cost, many will look at renal issues, but is the person planning to become pregnant? What is the degree of hyperglycemia? And can I manage or avoid hypoglycemia? So very important, because that leads to falls. I'm not going to spend any time on this slide, but I did include it in your handout because I find it very valuable to know what medications require renal dose adjustment. And I really like this because it was visual. And so green light, and so what we're looking up here at is glomerular filtration rate, or creatinine clearance. And it shows us the number needed to dose adjust. So green, go ahead, yellow, caution, red, do not give. So I quite like this as a table to look at, nothing that I need to memorize, but I can tuck away and keep. And also, most of us have access to pharmacists, so that's lovely. This is a table that I put together to help me understand all of the different oral medications, how effective they are, what benefit they may have to the cardiovascular system, what benefit they might have to renal system, and then what are the little idiosyncrasies that we need to remember as nurses when we're teaching patients. So as you can see, metformin is our frontline therapy. Its effectiveness or efficacy is very high. It says in a couple of these studies, there is potential CV benefit, but really that benefit is derived from achieving a normal hemoglobin A1C. Don't have to do a whole lot of adjusting until your glomerular filtration rate falls below 30. There are a lot of GI side effects to metformin that people don't tolerate well. And there is also a potential for B12 deficiency. So patients may need to be investigated for that. The next class of drugs that I have listed are relatively new, and they are really making a high impact. So the SGLT2 inhibitors, and the one that I have highlighted in yellow is probably the most commonly ordered in Canada. The trade name for it is Jardiance. It has an intermediate efficacy. However, it is shown to have significant cardiovascular and heart failure benefit. So much so that I will be interested to hear the 2020 heart failure guidelines when they come out, because they may even be recommending SGLT2 inhibitors in patients who are not diabetic but have heart function issues. So it'll be interesting to see what comes out of that. The one thing you need to remind patients of is, because their mechanism of action dispels or gets rid of glucose through the urinary system, this sets patients up for urinary tract infections and vaginal yeast infections in our female population. So please make patients aware of that. The next group or class of drugs is GLP-1 receptor agonists. And the most common one is Victoza, which is an injectable medication. It's not an insulin. And they're often taken maybe once every 24 hours or weekly. The biggest complaint that patients will have, and it is significant, is GI upset. So much so that the nausea prevents them from enjoying a quality of life. So if you're, warn your patient, and there is a potential of pancreatitis with them. The nice thing about it is there's no risk of hypoglycemia with any of the medications that I have listed thus far. The next class of drugs are called DPP-4 inhibitors. And the most common one is Januvia. And it's kind of a combination medication. There is no risk of hypoglycemia, and it just has an intermediate efficacy on what will do to our hemoglobin A1C. The next class of medications, I never know how to pronounce, and my pharmacist doesn't know how to pronounce, so that made, that kind of validated. But these are the glitazone medications, Actos and Avandia. And you will likely not see these much in the cardiovascular world because there is really an increased risk in heart failure patients. So we do not see those much in our coronary care because patients are at risk for cardiovascular disease for heart failure. And so we don't see those a lot in my province. And then the next or last class is the second generation sulfonylureas. And the most common one would be diabeto or glycoside, glyburide. There is a risk of hypoglycemia with these medications. So please be careful with that. And this is available in your handout so that you can share that with your colleagues. I've also included in your handouts a one-page sheet of insulins. All of the insulins that we have available, their onset of action. There are so many new insulins that we really struggle to know them and make sure that we're giving the right doses. So the ABCs of diabetes care, the B is optimal blood pressure management. And so you will hear one of my colleagues, Sarah Millville, talk later about the hypertension guidelines. And so right now we're targeting blood pressures that are above 130 on 80, or reverse, we're trying to achieve a blood pressure lower than 130 on 80. And what they look at is, does this patient have chronic kidney disease or cardiovascular disease? And so if the patient has either, then we're looking at an ACE or an ARB. And they're talking about not using combination medications. And when you delve further into this, basically that recommendation is because we are worried that using combination medications, we're not sure which part of the combination will cause hypotension. And so starting off with combo medications is not a recommendation. In those patients without chronic kidney disease, we are definitely looking at a thiazide type diuretic as our front line, but ACEs and ARBs have really gained in popularity. So blood pressure control is super important for renal protection. The ABC of the ABCs is cholesterol. And so we heard Krista speak a few minutes ago about what we should be doing and who should receive, who should receive, let me go ahead here, who should receive a statin. So patients who are known cardiovascular disease, age greater than 40, or basically diabetes for longer than 15 years. So again, please remember, that these guidelines are based on what is seen in the 2016 lipid guidelines. So that may change later in October. Who will get, I think my slides are out of order here. Who should receive a statin? Who should receive an aspirin? And back when I first became a nurse, nobody got aspirin. Mid-career, everybody got aspirin. And now we're really rather picky related to the cerebral bleed component of giving these antiplatelet medications. So in patients with established or well-known cardiovascular disease, we should be giving diabetic patients a low-dose aspirin. Aspirin should not be routinely used for primary prevention in patients that do not have cardiovascular disease and have diabetes. So if they have additional risk factors, we may potentially look at that. So sorry, I snuck forward and so the cholesterol, anybody less than 2, or we're looking for a reduction of greater than 50%. So just as Krista spoke of, anybody who's at risk, we will be adding statins, drugs to protect their heart, were what I refer to as ASA. A stands for ACE and ARBs, which, yes, are indicated especially for blood pressure control. Statin, so we spoke of who should receive a statin. And then ASA should only be indicated in patients who have cardiovascular disease. Now let's look at a little bit of what we recommend about exercise and healthy eating. So trying to do 150 minutes of moderate intensity aerobic exercise every week, including resistance exercise 2 times a week. Setting goals is super important, and I really want to spend a second talking about an exercise prescription. So you can see the look on patients' faces when a physician hands them 4 or 5 prescriptions. Oh, my doctor wants me to take these. These are important. When a physician or a nurse practitioner write a prescription for exercise, they are ramping up that importance for the patient. They look at it and say, well, gee, if they're giving me a prescription for exercise, then it must be super important. And having a plan. So this is from the Diabetes Guidelines website that just talks about having a step count prescription that you as the nurse in a clinic or on a floor discharging a patient could use in consultation with your physiotherapist. So I think that's important. Managing hyperglycemia. And there is such a judgment component to this. Being an overweight nurse myself, I know firsthand the judgment that comes when I say to people, yes, I'm a cardiovascular nurse. So people come in all shapes and sizes, and putting aside the judgment and leaving out the, hey, did you know you're fat? Because the last time I looked in the mirror, I already knew that. I didn't need a physician or a healthcare provider to come in and tell me that. So managing, asking the patient, this is what you normally do. What in this routine can we modify? And having the patient set goals is extremely important. Choosing a healthy plan for a diet, whether it is Mediterranean, a vegetarian or plant-based option, or a DASH diet to help me manage my hypertension. Keto is super in vogue right now. And for any of you who have ever worked in Nova Scotia or now who currently work in Alberta will likely know Dr. Blair O'Neill. Blair and his wife have started a lifestyle coaching business. And at one point in my life, I would have never called Blair overweight. But when I listened to a presentation and I looked at pictures of Blair pre-keto and post-keto, he really had me convinced that, you know what, managing a diabetic diet and managing hyperglycemia, keto may be the answer for some patients. It's not mainstream. Some cardiologists will plug their ears and almost roll over with laughter. But when you look at the clinical evidence that's out there, looking at LDL and what keto does to our LDL, there isn't a whole lot of evidence to tell us that it's a bad thing. So I'm not advocating for it. I'm just saying that there are many diabetic patients who have gotten their hemoglobin A1C under control with the use of keto. So when we look at screening for complications, so the micro and the macrovascular complications, retinopathy is very important to patient quality of life. So if you have a known retinopathy, then we should be screening every year or even every 6 months. And they are recommending that any sight-threatening retinopathy be treated with laser, pharmacologically, or surgical intervention. In the patient who has had diabetes within the first 5 years of diagnosis, we should really be encouraging people for annual or at least every 2 years screening with their ophthalmologist. Screening for kidney disease, super important. Screen, diagnose, delay, and prevent. So I know that Rody, when he speaks about heart failure, heart function guidelines, he'll talk about sick day management. Sick day management for diabetic patients and heart failure patients is really significant. And so looking at what is your albumin or urine albumin looking like in comparison to your creatinine, and ensuring that we have proper glycemic control, but also controlling our blood pressure with an ACE or an ARB. So a little comment about SGLT2 inhibitors and chronic kidney disease. There is evidence out there that tells us an SGLT2 inhibitor has proven renal benefit and should be considered to reduce the progression of a patient's neuropathy. So SGLT2 inhibitors are really making a strong defense for themselves. And yes, they are costly, but again, most meds, as we use them, the price comes down. Foot care, super important. Educate, examine, using a 10-gram microfilament. And I have never done this in my career, but I've always worked critical care, so that would make sense. But a special tool with a 10-gram microfilament, and these are the 3 areas of feet bilateral that we should be assessing. And so I have myself have had this done in my physician office. Screening for cardiovascular disease. Who needs an ECG? Anybody over the age of 40, their diabetes has been with them for greater than 15 years, or they've had diabetes and they're age over 30, and organ damage, so any evidence of cardiovascular or microvascular disease. And so I thought it was interesting. I didn't know that this was a recommendation. You're age over 40 and you're planning to undertake a vigorous exercise program. I know that they always say get your physician approval, but I didn't know that an ECG was indicated for this. I know that nurses don't like to talk about erectile dysfunction. It's uncomfortable, it's embarrassing, and oh my goodness, you know what? It's just like having a bowel movement. Everybody does it. So approach it in that fashion. You wouldn't be hesitant to talk about a stool softener to a patient, so why be hesitant? I often tell my new graduate hires that send me the old lady in to talk about it. Yes, I understand that it's uncomfortable as a new nurse to go in and speak to somebody who's your dad's or your grandfather's age about erectile dysfunction, but that doesn't mean it gets brushed under the carpet. Get your charge nurse. She's usually a senior nurse. Get somebody in the clinic who has that familiarity and have the conversation. It's important to patient quality of life. Smoking cessation, we do that so well, and nurses are in a pivotal role to ensure that that occurs. And then self-management, look at the barriers, develop a plan. Immunization, super important. Regular flu shots, pneumococcal immunization, very important. And so I'm just going to stop sharing. And I'm going to launch a poll. And I'm going to get you to answer the question. Oops. Launch a poll. So go ahead. And can you answer those questions? Are you able to do that, or have I snuck ahead too far? Oh, I see people answering. So let me share the results here. Has everybody had an opportunity? Only seen a couple of people respond. Oh, lost the poll. Okay, let me share it again. No, sorry, it didn't share the way I wanted it to. Relaunch poll. Okay, sorry for those of you who've done it once. And so in the interest of time, I'm going to end our poll and I'm going to share results. So when we looked at how do we manage Jane's A1C, so she was already on Janumet or Januvia, which is a combination medication that does have some metformin or metformin-like medication. So yes, if she had not been on that medication, we would increase her metformin and lifestyle modification. We may also add an SGLT2 inhibitor for sure. Jane doesn't have cardiovascular disease or diagnosed. So that really is left up to Yeah, I agree. Definitely, I'll have a short memory when it comes to the case. So she was 56, no known blood pressure, coronary events. So she does not need ASA for primary prevention at this time. And what would decrease the risk of major adverse cardiac events? Both ACE and ARB and the addition of the SGLT2 inhibitor. So would have been, okay, good comment. Thank you. Would have been helpful to have the history of the poll at the top. Thank you. I will remember that for next time. Awesome. So thank you. And we don't have much time for questions. I think I can probably take one question if anybody has any comments, questions they'd like. It was a very rapid overview, but again, you will have this available to you on our website. Okay. Okay, great. Thank you. So now I am going to share my screen again and end this presentation. And yes, so thank you for that. One of our colleagues has posted that Blair and his wife both work out of the Mazankowski Center in Alberta. So don't be afraid to let them know that Blair, a colleague from St. John, New Brunswick, was giving a plug for his business, and he can send any donations he would like to the Canadian Council of Cardiovascular Nurses. So now we're